Arrhythmias are common in acute MI, especially in the first few hours, and their most common is ectopics. These ectopics look like these. This is a normal sinus rhythm. The ectopic is a bizarre complex without a P complex, and it usually requires no treatment. Only thing, you just look for hypoxia and potassium immediately if possible, and if they are in the hospital, a beta blocker is a very useful drug in the absence of heart failure. AIVR is an accelerated ventricular rhythm. This is not a VT, it's a slow VT. It's not a dangerous rhythm, but it requires observation. It is usually a sign of reperfusion, but it also could be a sign of myocardial ischemia and drug toxicity. In general, it's a wait and watch policy for AIVR. This, like a saw tooth, is a dangerous rhythm. It is a ventricular tachycardia which can quickly go into VF, and in this situation, you have to either defibrillate the patient or use a drug to, like Cordron, to revert the rhythm to sinus. Now remember, in an ambulance, the ECGs may be shaking, and this should not be misdiagnosed. You can see here, it looks like a sawtooth of a VT. But if you look at this, you can see some P and QRS here. You can see a P and QRS here. You can see a P and QRS here. So it's basically the shaking lead which is creating this finding. This is an artifact, and this is not a VT. So it's important that you rule this out. But this is dangerous. This is a VF, and you can see it on the monitor, and in this page, the patient will quickly have no pressure and will code. So this patient should be defibrillated immediately to prevent further problems. SVT happens in less than 10% of patients with myocardial infarction. If it is a narrow QRS, a regular rhythm with maybe more than 200 rate, it can be treated with adenosine alternatives or beta blockers. AF especially occurs in large MIs. It occurs in about 10 to 15%. If the rhythm is very fast in AF and the pressure falls, you should shock and defibrillate. Otherwise, you can use drugs like Cordron for the same. Sinus bradycardias occurs in about 40% of acute inferior valve MIs due to vagal tone. Usually, it's responsive to atropine and the heart rate picks up. But if it continues to be hypertensive, then you may have to use drugs. And finally, if you're in the emergency room, you may have to put a temporary pacemaker from the neck line to improve the rate, especially if the patient degenerates into a more complex bradycardia like a complete heart block. So, first degree AV blocks are common. Nothing to be done, observe. If hypertension and problems, then maybe some atropine. Again, in first degree or secondary PR prolongation with Wenke-Back, again, most of the time, you can see the PR getting prolonged and a drop P wave QRS complex. This is a typical Wenke-Back. In these patients, you can give atropine if they're symptomatic. But progressive second degree and third degree either requires a transcutaneous spacing or a temporary wire through a line through the neck. Complete AV block could be transient in inferior valve. If the patients are stable, you still could monitor, but most often they require